I'm going to ask you, Sagar, some questions over this next little bit, trying to peer into the future. And maybe I'll let you just sort of kick off. If you were to be prophet, Sagar, for the next couple of minutes, can you predict 2 or 3 major things that will change significantly in the lives of myeloma patients or in the myeloma community in general as to what we're going to be either treating or diagnosing, or how myeloma is going to change radically over the next few years?
All right. Well, thank you. And thank you all for being here today. So I'm going to start off. I'm going to avoid the question. I'm going to pretend.
Yeah, well, see, he's a leader in management when he knows how to avoid the question.
I'm going to come to the question first, but I do want to address one thing that Jellic said, which is sometimes we poke fun at each other and our different centers. And quite honestly, we do that only out of a sense of camaraderie. Nobody, I think, in our field believes that anybody has the answer. I think we all believe that there are multiple paths up the mountain to try and cure this disease. And we may have our preferences, we may have our biases, and we poke each other because we know each other and we enjoy each other's company. And that's one of the things that I think really makes the myeloma community so unique. If you go to other diseases in cancer, you don't see that level of camaraderie. You wouldn't see the IMWG output that Jellic put up there if every disease, it wouldn't be unique for us. Every disease doesn't have that sense of collaboration and partnership that I think we have. And I consider myself very fortunate to be a part of that team because it is a lot of fun. It's a lot of fun for all of us to get together and just brainstorm. So I'm going to get to you.
I'll pay you later for that comment. That's fantastic. It was really well done. But it is true. I just want to emphasize that we've often had people from other diseases say, we need a version of the we need the leukemia version or the prostate cancer version of the IMWG.
I'd say good luck to them. But anyway, so I think when I think about what does the horizon look like, the first thing to say, again, getting back to that competitive spirit that we all have, is I'm right. And nobody can tell me I'm wrong because nobody knows the answer. And so I think the first thing I'd say is I think we're going to get to limited duration therapy. And what I mean by that is most of us now, if people are responding to treatment, will continue on that treatment until either toxicity or it no longer works. And I talked to somebody earlier today about being on Revlimid for 25 years or 26 years or however long it's been. That is the norm right now. But I think that the new classes of drugs we have are more effective at eliminating the clone as opposed to just controlling the clone. And that will be one revolution that I think we'll see. The second thing that I think we'll see, and then I'll stop.
Yep, no, it's good.
The second thing that I think we'll see is understanding how precursor disorders can predict for higher risk of developing myeloma. And we know that MGUS is an age-related phenomena and that it goes up as patients age. But I think we're going to get better at understanding which MGUS and which smoldering patients we should intervene early on and which ones we shouldn't, and potentially prevent patients from ever developing symptomatic myeloma. Those are things that I think we're going to be doing in the next 5 years.
Fantastic. Well, let's drill down on those two, and then I've got a couple other questions for you. So coming to the stopping of therapy, and I can't imagine that any patient in this room is going to disagree with that concept, right? How many people here want to stop therapy? All in favor, sit down. Right. Okay, good. So you're all with me, except one person who stood up right as I said that. There's always one in the crowd. No, but help me understand that a little bit more, because right now, we do have these glimmers of light, like when patients get a CAR T-cell therapy. In general, it's a one and done approach. We treat and we stop. We don't typically put people on treatment after CAR T. But for things like maintenance therapy, historically, we've just said, well, you'll take it. Not very many people get to over 20 years of Revlimid, but most people will go on for long periods of time. How do you think that's going to happen? Is that just going to be because we're going to develop different drugs and sort of the next gen? I know you've been a big part of the next generation of Revlimid drugs, the CELMoDs and things like that. Or is it going to be that we're going to have tools that can say, you're the person that we can stop right now instead of giving you Revlimid forever?
Yeah. No, I think that's a great question, and I'm gonna undermine your first premise with CAR T is one and done because we actually at my center I give maintenance therapy post CAR for the first 6 months, and I don't do it for the same reason that we traditionally give maintenance, which is we think there's something there and we're trying to treat it. I do it to try and wake up the T cells. So I think the biology of why we give therapy is going to change a little bit. When we give Revlimid now until progression, it's because we know that there's something hiding somewhere and that the Revlimid can suppress it but may not eliminate it. In the CAR T setup, we know that patients can achieve MRD negativity, and patients that achieve MRD negativity can have really long remissions. But even patients that are MRD at 10 to the minus 6 still have relapses. And so we've not eliminated the clone. And so what I think we're going to do, and again, this is the crystal ball, is I think we're going to use CARs to get to debulk, if you will, to get to really low levels of disease, and then come in with something like a bispecific on a different target for a limited duration to try and eliminate the escape mechanisms of relapse and then stop. So that's a totally different paradigm than what we currently think about, which is something works, let's just keep doing it until it doesn't work anymore. Now I think we're going to build on what we're doing to try and get better outcomes.
So it kind of fits actually for those of you here yesterday with part of the discussion we had around this notion that, coming at myeloma in different ways has led to such better outcomes. That's why we've gone from doublets to triplets to quadruplets, that even in lower doses of those different drugs coming at it in a different way. So what you're saying is that we could come up with some kind of strategy that says, okay, we're going to reduce the bulk of your myeloma with a certain strategy and then come a different way to get the rest of it. Sort of the analogy I sometimes give to patients is we really want to clean your kitchen floor, so we're going to sweep it first. That gets a lot of the dirt away, but then there's still something else. So now we need a mop, and so we get the mop, but then we need the scrub brush in the corner. So if we can predictably use the broom, the mop, the scrub brush in an order, then we can say we can stop scrubbing instead of just constantly sweeping all day long because dust is reaccumulating.
No, I think that's
with you.
That's a great analogy. And the way that I think about it in practice is many of you know BCMA is a target for many CAR T, the 2 CAR T cells we have approved. When patients are progressing after a BCMA CAR, those myeloma cells don't always express BCMA, or they're BCMA low, meaning that if all you did was just keep giving more BCMA-directed therapy, you're not going to get anywhere because those cells have already figured out how to get around it. So what you and I are talking about is you give a BCMA CAR, and then you come on the back end with something that targets GPRC5D or FCRH5, because that receptor is still there. It hasn't been messed with yet. And that's your opportunity to really try and scrub and sweep and mop sequentially.
Excellent. Okay, well, I think we got something with this mopping business, right? So hopefully most of you were here yesterday when I showed that picture of the myeloma cell with all those things that stick out of it, just to make sure we're clear that BCMA or B-cell maturation antigen was one of those targets, but we had those other 2 targets that Dr. O'Neil just referenced, GPRC5D and FCRH5. The other thing I want to drill down on a little bit with you in this vein, because it's a hot topic. I had 2 patients even already come to me and say, when are you going to talk more about this MRD business? So very quickly, we use these phrases, as I mentioned yesterday, we love to use words that patients don't understand. The second thing we love to do is create acronyms that people can never remember, right? So the acronym of MRD, or minimal residual disease, sometimes it's referred to as measured or measurable residual disease. It just is this notion that we can test for tiny amounts left of multiple myeloma. And it's not something we did historically because for the vast majority of patients, we didn't fully debulk their multiple myeloma. So you may remember yesterday, I commented that whatever measure someone has of their myeloma, their M spike, their light chain level, remember myeloma is a crime scene, as I said yesterday, that it's rare that one piece of information tells you the whole story. You need to look at the whole picture. But when that gets cut down by half, we call that partial response, or PR. When it gets cut down by 90%, we call it very good partial response, or VGPR. When it gets cut down,
our lymphoma colleagues always say, well, what about the NBPR? The not so bad partial.
The not so bad
A lot of those patients do.
Exactly. I thought they were asking about NPR. But anyway, so, and then when we get to 100%, we call it complete remission. But when we call it 100% complete remission, we know, just as Dr. Loniel said, there's still some disease left, right? If you look at the floor here at the Hilton, no disrespect to my homies here at the Hilton, it looks really clean, doesn't it? But I guarantee you there's some dirt there, right? If I get a wet Q-tip, I'm going to go down and show you that there's still a little bit of dust in those carpet fibers. MRD, or minimal residual disease, is testing for that tiny little bit of dust. And even with MRD, we have different layers of depth. Dr. Loniel mentioned that we have 10 to the minus 5, 10 to the minus 6. Those are just cutoffs of how many myeloma cells we can find and a certain number of other cells. So we look for one myeloma cell in 10 million or 100 million cells. So that's a tiny, tiny amount of dust in the carpet. But we know that although it may be a tiny amount, it could still grow back and be a problem later. So my question for you then, Sagar, is now that we're doing more of this MRD testing, and we don't necessarily have to get into the details of how we do it because there are different methods and so on, but what should a patient now know about MRD? And secondly, on the theme of the future of myeloma, do you think MRD is going to play a greater role in the way we decide on stopping therapy, like you said before, or completely switching gears of therapy? Is it going to be something, is it going to be a tool that's going to guide us a lot more in the future? And obviously I'm leading the witness, Your Honor, because I'm assuming that you're going to say it's going to be more used in the future.
Yeah, and I think it will, but I think we have to understand the nuances of what the test means and how often to get it, and what an individual patient's myeloma tells us. So every patient that's MRD positive, that was MRD negative, doesn't necessarily need to change treatment. And in fact, I would argue most patients don't need to change treatment. But let's do the first one. So can you use MRD negativity as a way to talk about discontinuation? So Jonathan Kaufman, one of my colleagues, has a series of 60 patients that he treated where if they were MRD negative at year 2 and year 3 after a transplant, he stopped their Revlimid. Now, our practice as a group is everybody gets Revlimid until either progression or side effects, regardless of what MRD or anything else looks like. Jonathan said, I'm going to carve out a group and we're going to see what this happens. And the control arm is my patients, where patients get it forever. And so preliminary analysis looks like that works. At 2 years, nobody in his group has relapsed. Now, we're going back and double checking all the numbers and the data and looking at progression-free survival curves to understand, but that kind of an approach may be useful to help us understand who needs to stay on versus who doesn't need to necessarily stay on. So that's one way that we could use MRD. I think the second thing is that can you use MRD to make decisions about treatment? And I'm not quite ready to say that somebody who goes from 0 to 100 copies needs to change treatment. Because when somebody goes from a CR serologically to an M protein of 0.4, I don't necessarily start them on treatment. So why would I think about this any differently? And so I think that's where the art of being a myeloma doc really kicks in. What do you know about that patient? Is it going from 0 to 900 to 5,000 in the course of 1 year? That's somebody I would be concerned about. Or is it going from 10 to 15 to 20 over 3 years? That's somebody I'm probably not that concerned about. So the subtlety of how to use those numbers and when to use those numbers and when to pull the trigger, I think is going to continue. This is why I don't worry about a computer replacing me, because it's experience and time that helps you know how to do that. And quite honestly, most community docs don't have either of those. They don't have the experience because they don't see a ton of myeloma, and they don't have the time because they're seeing lung cancer and colon cancer and everything else. So this is where being tied into a major myeloma center is so key to knowing how to interpret that data and maximize long-term outcomes.
That's great. And a computer can't wear that jacket the way you're wearing it. Let me just tell you that. But so he looks good, doesn't he? Yeah, he just like strolls out of Atlanta. Look at that. But I do want to emphasize that point because we have the privilege of hosting so many patient meetings. And I think sometimes, and at the IMF, we've been very excited about the concept of MRD. We've written blogs about it. We've done sessions about it. And a lot of patients come up saying, like, I need to know, I need to ask my doctor, am I MRD negative or not? And I've had patients come up to me and say, I found out that I'm still MRD positive, and they sort of feel like their life is crashing because of it. If there's one simple message to leave you about MRD, is that it's not that simple. Let me just emphasize a couple of areas to help you understand what I mean by that. So we have some patients who will never become MRD negative, but live a long and well life with myeloma. Our German colleagues just published a paper this last year looking at their greater than 15-year survivors. Almost half of them have never actually achieved a complete remission, let alone MRD negativity. So please don't think that it's MRD or bust, because that really isn't the case. Paradoxically, we have some forms of very slow-growing myeloma where having a little bit of disease seems to protect someone from their myeloma coming back. I can prove this to you in the lab. I don't want to get totally nerded out on you because I know Teresa's going to say you're getting into your myeloma nerd phase. But I always say my wife loves the fact that I'm a myeloma nerd, right? She always says, "I love it. You're such a nerd." I'm like, "All right, hey, nerds get good, get it good." So
we didn't rule in high school, but we do now.
Yeah, we didn't rule in high school, we rule now. That's right. Yeah, sweet. That's right. I wasn't really a nerd in high school, but anyway, we'll get into that. It's a little TMI. I think this is being recorded too. Sorry, Jake. Okay, but the point being is that if I took you into the lab, I can put a really slow-growing clone of myeloma into a mouse, and that protects that mouse from a more aggressive myeloma. So sometimes a little bit of naughty protects you from a lot of naughty. Right? Having a little bit of dessert saves you from going to the dessert buffet, is the way I put it, right? So myeloma is very complicated. So I don't want people to think that it's all about MRD negativity or not. In general, yes, achieving MRD negativity is a good thing. But Dr. Loniel said it beautifully. He said, in each individual patient, you have to be looked at uniquely. We said this several times yesterday. Multiple myeloma is called multiple myeloma for a reason. It really is different in every patient. All right, I want to move to your second major prediction of the future. This whole idea of predicting in advance who's going to develop myeloma. Do you think, Sagar, and I know I mentioned briefly yesterday the iStop study in Iceland, where we've screened nearly 90,000 people. We're gaining all of this incredible information. And I know it's a little bit premature to ask you, but this is the Future of Myeloma session. Do you see us reaching a point in the future where we're going to start screening people for myeloma? And maybe most relevant to our patient population, would we be starting by screening family members of myeloma patients? What's your thought about how that field is evolving?
Yeah, no, that's a great question. And we're part of a project with 7 centers that is trying to understand the risk of progression in smoldering. And at the same time, on the side, is going to be looking at screening for first-degree relatives of African Americans, because we know their risk is much higher, as Ice-T told us. So you
listened to Ice-T. That's good.
Ice-T. It was good. Yeah, I'm from the South. We drink iced tea, so it's okay. So I think there will be patient populations where we do embark on screening. I think the question about methodology, because I worry, and Dr. Dispenzieri is probably our in the room expert on this, but if you're using mass spec, you may start to pick up a lot of stuff that isn't really MGUS. And so understanding where to set those cutoffs, I think, are going to be really important. And that's where a study like iStop is critically important, because they have the numbers to help us do that. But I do think first-degree family relatives of patients with myeloma, I think we will eventually get to a screening process. And I suspect African Americans will look at screening as well.
Yeah, and I remind people that, when we determined how to screen for breast cancer, when we determined how to screen for colon cancer, it took decades to figure it out. And then it was very meticulous, right? We don't just screen every woman on the planet for breast cancer, right? We don't just screen every person for colon cancer. It's based on family history, on age, on gender. I had to be screened earlier for colon cancer because unfortunately my father died of colon cancer. So we were trying to figure out those riders now, but I think most of us feel that the highest risk groups are patients like myself of African descent, but also potentially family members. So the only other very pragmatic point I make here, because sometimes people leave a seminar like this and they start talking to their family about, should we be screened or not? Should we test it or not? If someone is asymptomatic, meaning they don't have any signs and symptoms of myeloma, is that does require a discussion and some thoughtfulness, because there isn't a recommendation to do that yet. And then honestly, on a very pragmatic note, I think I mentioned yesterday that I had a family come in to see me where there were 3 siblings with myeloma, and they had 2 other siblings who were considering testing. You know what I told those 2 siblings before we tested them? I said, I suggest you get your life insurance in order now before we do the testing. I'm not trying to beat the system. I'm just trying to be very pragmatic that once you have MGUS, it's much harder to get life insurance. One of the most riveting conferences I have ever attended was the American Association of Insurance Medicine. I'm almost tired saying it. Anyway, no disrespect to anyone who's a member of the AAIM. I know it's a just riveting conversations. But I remember I met with them because they said, is there a possibility for us to ultimately insure people with MGUS? And they're debating that. But at present now, if you have MGUS on a test, it is going to significantly impact your ability to be insured with life insurance and the rates that you might pay. So just very pragmatically, if someone's going to go get tested for it, I might suggest that they get the insurance in advance.
And I just want to go back to highlight something that you mentioned a moment ago, which is about the iStop study. So
Please.
The iStop study, first of all, is a phenomenal opportunity that Iceland is one of the few countries in the world where you could do this, because everybody lives sort of in the same place, and,
right.
And you have access to, I think everybody's had their genome sequenced in Iceland.
Almost, yep.
Yeah, so, it's the kind of place where you could do this. And that study would not exist without the support of the IMF. So I think that's the first thing to say is the IMF came out early and really pushed for this kind of a screening study to be done. And so it will tell us whether screening actually makes a difference. The challenge I have with iStop is that it's a very homogeneous patient population, very white, very Northern European, all Vikings, I think, and not Minnesota Vikings.
Yeah, no, I get it.
But it doesn't necessarily answer the question about African Americans and screening, which I think is a separate issue, and I think we need to do that kind of work here to answer that question.
And if only we had our Vice President of Development and Philanthropy to later talk to us about what we're doing for Iceland. Sylvia will come and talk to us a little bit later. As some of you know, coming up in just a couple of weeks, and believe me, I know because I've been training every day for it, a group of us are going to be cycling across Iceland to raise further funds and to raise awareness of myeloma, and for the project, the iStop which stands for Iceland Screens, Treats, or Prevents Multiple Myeloma, and the project that we're doing. That being said, also our colleagues in Charlotte are just about to launch, and we're working as the IMF with them, about to launch a much smaller scale, but a similar kind of concept of screening population of African-American patients in the North Carolina region. And so you're very right. iStop had to be done in Iceland because it was the right place to do the testing and to understand it. They have a universal healthcare system, so we could look for things that otherwise we couldn't, but it clearly doesn't reflect the diversity of the planet.
So if you're going to use the Iceland biking thing, by the Myeloma Doc Activity Index, where we compare how fit each of us are, you get no credit because it's flat. You can bike for 100 miles, you get no credit because it's flat. You got to go up.
So
I'm just saying.
If you've seen the landscape of Iceland, it's very much like a serum protein electrophoresis, right? There's lots. Let's just say the M spike that I'm going to be climbing will be disturbingly high. But all right, there's my nerd gene being activated again. So Sagar, we have about 3.5 minutes left, and I just want to give you an opportunity for us each to give a little sort of closing thought about anything else, sort of looking into the future that excites you about myeloma.
Yeah, I think, and people have given this trial many different names, but for 3 years now, we've been trying to put together a trial that basically takes all of the immune targets in myeloma and exposes a patient to those sequentially over the course of 2 years of therapy. And the idea of, I mean, we talked before about if you hit with BCMA, does it make sense to continue to sort of flog BCMA? Well, it doesn't, because myeloma cells are smart. And if you hit them with one thing for too long, in many cases, it's going to figure out a way to get around it. And so the idea of keeping myeloma off its heels and saying we're gonna continue to change the target, we're going to continue to not let you evolve and hit you with every immune target we have. And right now we have 5 or 6, I think, in myeloma in a defined period of time. That's a trial we're trying to shop around right now and are very close to being able to open next year, where it's 2 years and then you're done. And the goal is to achieve sustained MRD negativity, hitting BCMA, CD38, FCRH5, GPRC5D, and using PIs and cell mods at the same time to sort of augment each of those different phases. That, to me, is really exciting because it's limited duration therapy. It's not like ALL therapy where you're sick for 2 years. Most of these treatments are very well tolerated, and we have the tools. So now that we have the tools that we didn't have 2 decades ago, it's our responsibility to put them together in a way that changes the paradigm and ultimately increases the fraction of cured patients.
That's beautifully said. It's hard to add anything to that, but my only addition to that is that I'm very excited about the very same thing, this sort of next generation of immunotherapy. I mean, as we talked yesterday, the whole concept of immunotherapy, of engaging someone's own immune system to destroy myeloma, is a brilliant concept, and it's now gone way beyond a concept to actually pragmatically having multiple therapies approved and more coming. I'm excited about the ones that are coming. I shared yesterday that, you know, there's no drug in myeloma we use today the way it was first introduced. Everything goes through an evolution. As that evolution happens, I think the fraction of patients, whether we call it cure or whether we call it long-term control off therapy, we can debate, but I think that fraction of patients is going to considerably increase. And it's all under the tenure of what Jellic shared with us earlier too, that the patient engagement in these trials and in this approach is so important. Because I said it yesterday, Teresa said it yesterday, we don't treat myeloma, we treat people. And so being able to capture in real time the real world evidence, as we call it, of the patient input at meetings and in situations like this, where you tell us, because I can look at your, as the nerdy scientist, I can look at your marrow and say, hey, you only have 1 in 100 million cells, right, that are myeloma cells. But if you're feeling terrible, what's the point? So being able to do so in a way that supports your quality of life, the way you define it, so that you could enjoy life the way you want to enjoy it, is really our ultimate goal. And that, to me, is a very exciting future of myeloma. And when Sagar and I started in myeloma, I won't tell you how many exactly years ago it was, you know, as I mentioned yesterday, our average patient sadly lived 1, maybe 2 years. But now we're seeing patients live longer and live better. Living life to the fullest is, of course, our objective. So, Sagar,
just for the record, that inflection in the survival curve was when I started in the field.
Right. Yeah. Okay. That's right. Yeah. You know, it's the humility that always draws me to Sagar. Right? Thank you, Sagar.
So I wanted to highlight why you need a myeloma specialist on your team. This was not a prepared conversation that they have had. They have not rehearsed this. And for me, I always say a myeloma expert is someone you shake up in the middle of the night, like 2, 3 a.m. in the morning, and wake them up and ask them a myeloma question, and they will be able to answer you that, give you the answer. So these are why you need people like this on your team. So thank you.